All right, we're going to get started. Thank you so much to everyone who has joined us and logged in. Welcome to the September Medcan online seminar, The Powerful Potential of Specialized Genetic Testing with Allison Hazell, the Clinical Director of Genetics at Medcan. My name is Tanya Haas, and I'm the Health and Wellness Writer here at Medcan. This will be recorded and available on medcan.com in the coming weeks. Now, for all of those who are joining us for the first time, you have the opportunity to submit questions throughout the seminar if you'd like to ask Allison something. And you can do that in the screen if you type in the bottom left corner, the area that's circled here on your screen. This is the area where the presenter will have time to address a few of the submitted questions, and we only see the questions by the presenters, and they will remain anonymous. And please note, it may not be possible to answer all the questions in the time we have today. And finally, the information in this online seminar is for educational and information purposes only, and is neither intended to be relied upon nor to be a substitute for professional medical advice, diagnosis, or treatment. With all that being said, I am delighted to introduce our presenter today. My colleague, Allison, is a Canadian and U.S. board-certified genetic counselor based here in Toronto. She is the president of the Canadian Association of Genetic Counselors. Allison joined Medcan in 2010 and prior to this held a position at the Adult Genetics Clinic at the University Health Network, Mount Sinai Hospital. She earned her master's in human genetics from Sarah Lawrence College in New York and holds a certificate in public health genetics and genomics. Now, Allison, I know we didn't even include half your bio. You have quite a background, but to be honest, I'm not even clear what a genetic counselor does. Would you be able to speak to that before we start the presentation?
Yes, of course, and I think that's, you're not alone in that question. I think that's something we hear a lot. So genetic counselors typically work as part of a healthcare team. Our focus is really on assessing genetic risk based on personal and family history, helping to facilitate decision-making around genetic testing and communicate genetic test results and impacts for family members.
Okay, great, thanks. That clears things up. So I'm going to pass the microphone over to you. Thank you, Allison.
Perfect. Well, so before we kind of dive in, I just wanted to give you a brief overview of what I'll be going through today. First, I'm just going to touch on some headlines, genetics in the news, kind of what you may have read, and provide some text, and then really focus on what we are excited about right now in terms of clinical genetics and where things are going. And hopefully we'll leave lots of time for questions as well. So moving on to kind of the headlines, I think there's no shortage of genetic headlines in the news. Kind of some big stuff came out recently where there was the first genetic sequencing actually happened in space this summer. The picture you see here of a smartphone with a little attachment, that's actually a sequencer that can kind of sequence genetic technology. So, you know, these things are exciting, and you'll hear more about them in future years. We talk a lot about or hear a lot about genetically modified foods and more recently mosquitoes and the Zika virus. In terms of the kind of celebrity type news, we have Angelina Jolie, who I'll touch on again a little bit later. She made headlines around her BRCA diagnosis a few years ago. There are some headlines that kind of, I think, play on fear a little bit. This is one, again, I'll speak to a little bit later, but a woman finding out she has cancer based on a prenatal test. And then CRISPR, which is something, if you're interested in genetics, you've probably heard about this. This is a new kind of gene editing technology that's recently become available, and it's the big hype in the genetics world right now. Obviously, anytime we talk about gene editing, we then get into sort of the kind of ethical issues and that stuff as well. So kind of moving on from that, kind of getting into what we are excited about, I think the main thing to know is that, you know, even this stuff is confusing, and even if you work in the world of genetics or genomics, it's hard to decipher kind of what is real and what is, what is kind of hype and not so applicable. So what I'm going to focus on are things that we're sort of excited about and are kind of going to be applicable in the clinical genetics world.
So it seems like the field is constantly evolving. There's so much going on. I mean, it's hard to decipher. Your clients and people that you speak to must be confused and excited at the same time? Is that common?
Yeah, I mean, I think it's an area that is exploding, and it's very exciting, but it is, the more we learn, the more we realize we don't know, and there's a lot of education and things that we have to kind of constantly keep up to date on. So kind of moving into the first area, so hereditary cancer panel testing. The main kind of innovation here is really plummeting cost of sequencing technology. It's much cheaper to sequence genes now than it was 2, 5, 10 years ago, and also a change in patent laws, which I'll touch on as well. But before I get into that, I think one of the key things is understanding what hereditary cancer is. And so when we're thinking about hereditary cancer, obviously we want to contrast it with common cancer. So most cancers, 90 to 95% of cancers, are considered common complex disease, meaning there's genetic components to it, but there's a significant environmental contributions. And those are the things you hear about, like what you're eating and smoking and exposures like asbestos. Most of these cancers are diagnosed in people after the age of 50, and your risk for common cancer will increase as you get older. Hereditary cancer, by contrast, is really much more rare, and in families with hereditary cancer, what you tend to see are multiple people affected with the same types of cancer, usually diagnosed under the age of 50 and kind of multiple generations affected. So those are some of the red flags that we look for when we're talking about hereditary cancer. In hereditary cancer, the genetic factors are much stronger. So it's a very significant genetic mutation that causes a change in the gene that really, that's the reason for the cancer in that particular individual or family. Environmental factors play a role, but it's not as it's not as strong.
Right. So for some of us looking at the slide right now, it might seem, we're thinking about people in our families and perhaps looking at our own family history. Is that part of what you do when you're sitting down with someone? Yeah.
So generally, what we will typically do is go through a pretty detailed family history with an individual and look at what cancers are diagnosed in who, what the kind of relationship is, the ages of diagnosis, the types of cancer, and really give someone a general kind of understanding or assessment about whether it looks like it's suspicious for hereditary cancer syndrome or whether it looks more like it falls into kind of that common category.
And how does that work? It's so conceptual.
Yeah, so I think one of the metaphors that I use a lot, and actually we move to the next slide, that is kind of like a needle in a haystack, right? So, if I'm sitting in front of someone and they have a family history of cancer and it looks like it's suspicious for hereditary cancer, when we're trying to find the genetic mutation that's responsible for the cancer in the family, it's really like looking for a needle in a haystack. So what traditionally has been done is very targeted testing. So if you think about kind of looking at very specific spots in that haystack and kind of sifting through it and looking for the needle, and traditionally it's also been done pretty sequentially. So you kind of start with one particular area. If you don't find anything, then you move on to the next area, and so on and so forth. So it's been a pretty targeted process. So if we kind of go forward to where we are right now, one of the things I wanted to touch base on is Angelina Jolie's story. So in 2013, she published an op-ed in the New York Times that really described her experience with hereditary cancer genetic testing and her decision to undergo a double mastectomy as a prophylactic surgery. So really to reduce the risk of developing cancer for her. So just as a bit of background, for someone who has a BRCA1 or BRCA2 gene mutation, those are common mutations, those are rare hereditary cancer mutations, but the hereditary breast cancer is really the most common hereditary cancer syndrome we know about. And if someone carries that mutation, their risk for breast cancer is going to be potentially as high, some studies will show as high as 85%, and ovarian cancer risk as high as 45%. And there are also increased risks for other types of cancer, such as pancreatic, prostate cancer, and melanoma. So what Angelina Jolie did in 2013 in a single op-ed is really, she kind of did more to raise awareness of this particular syndrome in one single op-ed than the genetics community has been trying to do in 20 years.
Yeah, that whole experience seemed to make it much more easier to talk about, and people were able to recognize the benefits and how it could really help someone. So it's really opened up the doors, but we're focusing a lot on breast cancer, but you're saying that other cancers can also be detected with this type of your specialty.
Yeah, so I will use breast cancer as an example, but we do know of hereditary colon cancer syndromes, for example. There's lots of markers associated with pancreatic cancer and things like that. So there are other hereditary syndromes out there. So to kind of go back to the hereditary breast cancer, the BRCA piece, in about a month later, so about in June 2013, the U.S. Supreme Court basically ruled that you can't patent a gene. And up until that point, there had been one lab called Myriad Genetics that had a patent on the BRCA1 and 2 genes, and so no other labs were really able to offer testing for that. So this ruling really changed things and opened up the market, obviously. So now you have a lot more labs that are able to offer testing, and what has happened is those test offerings have really been now bundled into a panel. So a gene panel is basically looking at a number of different genes all at the same time, and often genes on a panel will relate to a single condition. So we're looking at markers related to breast cancer, hereditary breast cancer specifically, or hereditary colon cancer specifically, and you really use the family history to guide what you're looking at. The benefits of panel testing really reduced cost, greater coverage, so we're able to look at more and get more comprehensive data, and more efficient, right? So if we're going back to that needle in a haystack reference, so if we're thinking about the kind of targeted testing that was traditionally done, we're now able to more broadly and more quickly look at a wider area of the genome and get people results more quickly. Yeah, so
that's clear. Thank you so much. Yeah.
So I wanted to touch on this. Is Maryclaire King is a geneticist, and she's actually credited with finding the BRCA1 and 2 genes. And there's sort of a shifting discussion, I think, in the cancer genetics world. So right now we really wait to see, we choose who to test based on who has a significant family history or personal history of cancer. And what Maryclaire King is sort of advocating is that actually to identify a woman as a carrier of a genetic mutation only after she's developed cancer is really a failure of cancer screening and cancer prevention. So her kind of radical, her radical approach or proposal is that every woman at age 30 gets screened for these things, and so you're able to detect it early. So that's sort of in our circles how the conversation is going and whether we should be changing our approach to these things.
It's very exciting. Is that a universal feeling among genetic counselors, or is there a lot of debate? Or
so I think if you move ahead, just to kind of give you a sense, the different panels will have different number of genes, and so one of the things that commonly patients will ask us is why not do more, right? So if you can do more genes for the same cost, why not do more? And I think the genetic counseling piece really comes into it because there is a lot to consider when you are kind of digging into the genome in this way, and there's different types of results that you can get. And so the kind of pre-test counseling piece is actually a really important part. So it's not as easy as just testing everyone. I think there's considerations and people are going to make different decisions based on kind of their personal preference and their situations. So kind of taking this a little bit further, so we're kind of with hereditary cancer, we're really kind of individualizing medicine on a more rare kind of scale. Pharmacogenomics really represents the kind of true realization of individualized medicine. So we have the kind of main innovation here is that there's again plummeting cost of the sequencing technology, but also significant research discoveries in understanding how individuals metabolize certain prescription medications. So if you look at this slide here, what happens right now is kind of all patients are given a standard dose of a drug, right? So the doctor is deciding to put you on a medication, and they will say, this is the standard starting dose, and then we adjust from there. So 3 months later, it doesn't seem to be working, you increase it a little bit, or someone's getting significant side effects, you decrease it a little bit. So what this is showing is that people will differ in terms of whether they're getting kind of toxic buildup of a particular medication, whether it's working well for them, or whether it's actually not working at all. So with pharmacogenomics, what we're really trying to do is take away some of that trial and error. It is a significant issue. In Canada, it's estimated that about 200,000 severe adverse drug reactions happen per year, claiming about 10,000 to 22,000 lives and costing the healthcare industry quite a lot of money. So kind of when we are looking at that, we basically are gaining a better understanding in terms of the absorption and distribution of medications, the metabolism, and kind of how they're excreted, and using that information up front to avoid these kind of adverse drug reactions in the first place. So there's obviously a number of factors that influence the effects of medications, so listed here: age, body mass, kind of whether you're a smoker. Genetic factors are a piece of that, and they can account up to 95% of drug response variability and susceptibility.
That seems like a really high number, 95%. Seems like, imagine we haven't been using this technology and we've been, giving patients certain medications that they just have to wait and see how it's going to work.
Yeah, so I think that's kind of been the standard of care, and that's how we've done things. But this is really, I think, poised to revolutionize how we prescribe medications, and really the main goal is taking away that trial and error and getting someone on the right drug at the right time. Currently have probably about 250 different medications that we're able to do this type of testing for. So it's expanded quite a bit in the past few years. And yeah, the main goal here is to get someone on the right medication at the right dose at the right time. So moving on, liquid biopsy. So this is something that is still very new, and this is not something that's currently kind of in clinical, the general clinical genetics practice at this point, but it's something that's on our radar and is very, very exciting. So if I go back to that headline about the woman who had a prenatal test. So essentially what this is Eunice Lee and her son Benjamin, and she at 10 weeks in pregnancy, she had a non-invasive prenatal test to look for chromosomal abnormalities for the pregnancy. And from that test, actually, it was determined that she had colon cancer. So she was successfully treated for colon cancer and is doing well. But what we've found is that this NIPT testing really has highlighted actually another use for the test. So just to quickly give you an overview of what NIPT testing is, essentially, when a woman is pregnant, there are fetal cells that are circulating in her blood. And so one of the things that researchers have tried to look at for a long time is isolating those fetal cells and being able to test them for these things, so you don't have to do something like an amniocentesis. But what we know actually is that those fetal cells will die and open up and release their DNA into the bloodstream. And so we are now able to test these small fragments of DNA in maternal blood. So the kind of extension of that is actually cancer tumor cells will circulate in the blood as well. And again, researchers have spent a lot of time trying to isolate those tumor cells as a way to kind of detect cancer. But because cancer cells have a very high cell death rate or apoptosis rate, they will also die and release these small fragments of DNA into the blood. So researchers can similarly look at these small fragments and detect the kind of circulating cancer tumor cells in the blood. So this is really exciting. I think the term liquid biopsy is basically refers to a non-invasive blood test that can detect these circulating tumor DNA. It's currently only validated as a tool for post-cancer monitoring for a handful of cancers, and it is a reliable method for detecting effectiveness of cancer treatment in an individual. So just sort of seeing, if the cancer treatment is working, you would see these kind of fragments of DNA going down. And it's most accurate if the genetic mutation of the tumor is known. But really what this is being called is sort of the holy grail of cancer prevention and cancer screening, right? If you could detect cancer before an actual tumor has developed in those very early stages, you're in a very different phase in terms of prevention. So the kind of future applications of liquid biopsy are broad, and I think you can imagine maybe standard screening for high-risk populations and known carriers of hereditary cancer, smokers, people over 50, and even kind of taking it beyond that, general population screening, so that as part of your your yearly meeting with your doctor and blood work, this is part of that. So this is something that has us very excited. We're not doing it yet. There's still a lot of validation that needs to happen, but it's something we're looking very closely at.
Great. Well, thank you, Allison. We've now entered the question period of our presentation. So in a moment, we will be addressing questions. Allison is now going to review those that have been submitted. If you haven't already, feel free to write your questions down in the corner of your screen, press enter, and again, these questions will only be seen by the presenters and will remain anonymous. I'm going to take one moment here just to speak to genetics and genetic counseling at Medcan. As you've heard Allison mention, genetic testing at Medcan offers a better understanding of the risks you may face so you can better manage your health moving forward. Using a team-based approach with health information collected from our annual health assessment, genetic analysis provides wide and deep insight with the helpful guidance and support of our genetic counselors who are at the center of our service. And as Allison said, interpretation is important with genetic testing, and your genetic counselor will put your results in context of your personal and your family history. This perspective is the basis of the information you'll need to make informed and confident medical and personal decisions. For more information, please visit medcan.com or contact our genetics coordinator at the number provided on the screen, and we also have our email address there. So now we're going to move to the questions. Thank you very much for those who have submitted. So you had spoken about, the first question is regarding policy, and so you had mentioned about some American policy on genetic programming. What about Canada? And they also asked about discrimination laws and insurance coverage. So is that something that you could address?
Yeah, so definitely the insurance question is one that we get often, and it's a very good and very valid question. So right now in Canada, we don't have any laws that protect an individual from an insurance company discriminating against them based on their genetic information. So, typically insurance companies will use family history and smoking status, but if someone is found to be a carrier of a hereditary genetic syndrome, so they're known to be at 80% risk for breast cancer, but have never had cancer themselves, the insurance company can use that to then deny coverage or increase premiums. So it's an issue, and it's something that we kind of deal with on a daily basis in terms of talking with our clients. So that's one of the things that we want people to consider when they're doing predictive genetic testing, right? So the situation is very different if you've had cancer already and you're doing genetic testing to determine the cause of that cancer. You're going to be discriminated based on your cancer diagnosis. But when you're healthy and doing it in a predictive setting, it's a different scenario, and it's something that people need to be aware of. There are some kind of good strides happening right now. So there's a bill called Bill S-201 that's currently very shortly actually having its second reading and first debate in the House of Commons. So that's something that the genetics community is strongly supporting, and we're putting as much kind of support behind that as we can. But yeah, as it stands right now, it's not something that we have coverage for. In the U.S., by contrast, I'll just mention there's the genetic insurance
Briefly, you spoke about breast cancer, colon cancer. What other diseases can you screen for? What do you do here at Medcan?
So we do the hereditary cancer panel testing, which I talked a lot about, and there are different cancers that you can screen for there. There's some cancers we know off the bat, like lung cancer, for example, example, doesn't tend to have very strong genetic, right? That's one that's more commonly associated with smoking or environmental exposures. We also offer personal genome testing, which is testing for common complex disease again. So those conditions where the genes play a smaller role in comparison to those rare hereditary syndromes. And that testing is really done in the context of being preventive and giving people some advice about where kind of they can get the biggest bang for the buck in terms of putting their preventative efforts. So those panels are things like heart disease and diabetes, and we look at markers related to late onset Alzheimer's disease. So that's sort of the other area.
Okay, thanks, Allison. We have another question as a follow-up to the insurance and that you were speaking to. So further to the insurance question, how do the insurance companies know your results?
So the insurance companies will. It's actually, it's not uniform based on each insurance company, but often there will be a question, have you ever had any genetic testing, yes or no? And so you're kind of required to disclose that. In the context of testing that has impacted your medical management, then it will be in your kind of medical file. So if you're signing consent for the insurance company to access your medical records, then it would be there.
Well, it's definitely an evolving field, and it's constantly changing, especially with the law before Parliament and possibly getting passed within this year or perhaps early next year. So we'll be following that closely. Now, what about children? So if someone in family has had a condition, whether it's the pharmacogenomics or if they're being treated or disease detection, are children eligible for this type of counseling?
Yeah, so there are a number of different conditions that are childhood onset, and just kind of theoretically, the younger you are when you develop a condition, the more likely it's genetic, right? So if you're 80 and you develop cancer, it's probably a lifetime of environmental exposures versus if you're 20. So in terms of rare hereditary testing for syndromes, there is a lot that's available to children, and there's specialty clinics in that area. One of the distinctions that we make is genetic testing for an adult onset condition in a child. So if it's going to be an adult onset condition, you're not going to do anything differently in terms of medical management in a 6-year-old, right? So what we try to do is wait until that individual, that child, is old enough to really understand what the testing is and what the implications are, and making sure that they have some kind of role in the process. So we don't routinely test children for adult onset conditions. It's sort of one of the kind of hallmarks of our field.
Okay, so we're wrapping up. So we have one more question, and this might be, I'm not sure if we have people from different provinces, but who is eligible for screening?
Yeah, so there is. It depends on the province, and there is a lot that in Ontario, for example, the Ministry of Health will cover. So in the case of hereditary cancers, for example, if there are 3 individuals in the family with breast or ovarian cancer, and they're diagnosed under the age of 50, there's coverage for that testing. Or if an individual is diagnosed with colon cancer at 30, they will automatically be qualified for OHIP-funded testing. So it really depends. There's different criteria for different health conditions, so it really depends on the family history and personal history and what the condition is, to be honest.
So what is the best action that someone should go to their primary care physician, or should they book an appointment with a counselor? What's the recommended step?
So yeah, typically how someone gets to a genetics clinic is by talking to their primary care provider or specialist about a referral to a genetics clinic, and then based on that, it will be determined whether the genetic testing they're eligible for OHIP-funded genetic testing or not.
Okay. Thank you very much. I want to thank you for your time and your expertise, Allison. It was a pleasure hearing from you. And this concludes our online seminar. You may be receiving a survey. We'd love to hear about your experience, what worked for you, what didn't. And if you'd like to share this online seminar with anyone in your family or your colleagues, it will be made available on medcan.com. You can look up online seminar and you can see all of our previous online seminars that we have done in the past few months. Many thanks for everyone who joined us, and good night.